The LINKER-MM1 study was a step-up dosing way of finding basically what our phase 2 dose is going to be moving forward. And it was evaluated across dosages ranging from around 5 milligrams up to even 800 milligrams. But what we found with the data so far is for a while it looked like the 50 milligram dose was going to be kind of the way to go. But part of that was simply because it was an earlier dose, people were on it for a longer period of time. But then we started seeing the data for 200 looking even better. And even better than that, the PK/PD data shows us that although with the 50 milligram dose, we have to stay at every 2-week dosing after hitting week 14, with the 200 milligram dose, once you get to week 24, we can easily switch to a monthly dosing schedule. So after we kind of got more of that mature data, that's the direction we're going to head, not only with the remainder of this study, but future studies as well. Patients who had at least 3 lines of prior therapy, including an IMiD like lenalidomide, a PI like bortezomib, and an anti-CD38 monoclonal antibody like daratumumab. So these were heavily pretreated groups of patients, and there were a median of around 6 lines of prior therapy for the people in the 50 milligram cohort, but in the 200 milligram cohort, which is 117 patients, there were an average of 5 lines of prior therapy, ranging from 2 up to 14. Now, in general, these were heavily pretreated patients. If you think about the modern day approaches in initial lines of therapy in myeloma, if you get Dara RVD up front, you can already be triple class refractory moving into your second line. As such, these were heavily pretreated. All the patients were triple class exposed. About 3/4 of them were penta exposed. And of that, probably around 1/4 were penta refractory in the 200 milligram group. So we're really looking at patients in this population with linvo who have progressed beyond our standard novel agents. I think when it comes down to these drugs, we have to get to nitty-gritty of safety and efficacy. And from a safety standpoint, I think that there are 2 main toxicities that we look at when we talk about T-cell engaging therapy. One are the long-term toxicities like infections, and those are actually fairly similar with their other assets. But what is most notable here is the CRS rates. Now, again, it's very difficult to do cross-trial comparisons, but we know that in many other drugs in this asset class, the all-comer CRS rates have been seen around the 70+%. And if we look at the 200 milligram dosing cohort here, we saw around a 45% all-grade CRS, with the overwhelming majority, basically everyone except 1 patient, having either grade 1 or grade 2 CRS. So overall, the immediate safety issues, the things like cytokine release, seem to be very, very impressive in the study population. From an efficacy standpoint, and this is where we really see distinct advantages of the 200 milligram dosing over the 50 milligram dosing, is that we can see that although the median progression-free survival was met for the 50 milligram dosing cohort, they do have a little bit longer follow-up. So far, the median PFS is not yet reached in the 200 milligram dosing cohort. And if you actually look at the data curves, it's kind of flat at the moment. So crossing fingers, but so far this seems to be an extremely efficacious drug in a very heavily pretreated group of patients. I think there's a few areas that are being investigated right now with linvoseltamab, and this is across the board. So number one, there's the ongoing LINKER-MM3 study looking at the phase 3 data comparing linvoseltamab with some other industry standards like elotuzumab, pomalidomide, and dexamethasone. Then there are 2 other big areas. One is looking at this asset in other plasma cell dyscrasia states, so looking at it in precursor disorders like MGUS or smoldering myeloma, looking at it in diseases like amyloidosis, and then in the myeloma space specifically, either using single agent in earlier lines of therapy, in early relapse, and also some combination studies, such as data looking at combinations with some of our other drug standards, like combinations with lenalidomide, pomalidomide, bortezomib, and daratumumab.